Okay, so this is pelvic images in a young patient, young female patient. Patient has history of severe abdominal pelvic pain, and these are some of the images. Let me show you the coronal. We did an abdominal and pelvic scan. So these are the post-contrast images. And then let me scroll through the post-contrast image in the pelvis. So we are wondering what is the cause of the abdominal pain, and especially what is this lesion over here, and how we can tie all the findings. So we have a cystic lesion which has got a solid enhancing component right here. It abuts the kidney, and we have the ovary over here, and we have a cystic area around it. So any thoughts?
Thinking. The one in the left abdomen, can you actually zoom in on that? Yeah. What is that? It's crazy looking. Initially I thought it could be like an extra kidney.
Right, and we also thought that maybe it has got a renal origin, but it doesn't look like, it doesn't have that claw sign. It just abuts that, but it's a retroperitoneal location. So the question is like, what really triggered us kind of towards the most likely diagnosis? We don't know as yet, because this is not path proven as yet, but what really clued us in was the thing like, where is the other ovary? Right.
Yeah,
so
but I was wondering about that, but I haven't heard about an ovary migrating into the retroperitoneum.
Well, there's always a first time. So that's what we are thinking. That's our provisional
Can you
diagnosis.
trace the gonadal vessels?
It's very tough. I think it's, you can see here. Let's see, right there, right there.
Yeah, it goes to it. The left gonadal.
So the thought process here was that since one ovary is missing, we really could not find it in the pelvis. So what if this is an undescended ovary? And this is a young patient, has got chronic abdominal pelvic pain. Then we dug into the history, and we saw that the abdominal wall is a bit deficient and thinned out. And then upon further digging, we found out that this patient had a history of gastrocecious repair as a neonate, has several surgeries, and has problems with constipation and abdominal pain throughout the childhood. So we thought of like, maybe it is either to do with the surgery, maybe somehow the surgery itself caused adhesions, and that kind of caused this thing, or it is a primary non-descent of the ovary. And fair enough, it's like both things have been described. So let me show you this here. So this is actually exactly so there's a case report on an ectopic ovary in an adolescent patient with had history of gastrocecious repair, and no such cases have been described as per that case report. And they had a similar case where it was on the right side, and then they decided to take it out because they thought that because of the adhesions, it's causing recurrent pain. So So that was one case. Then there is another one where they
Wait, and in past it was ovary?
yes, it was ovary. And then there was another thing. This kind of article goes into like the details of the embryonic development, how ectopic ovaries can occur, and they're very rare, not as common as the undescended testis, but the mechanism, what they say is the same. It's the arrest of the orderly descent of the gonads. And the other thing what they talk about is that it is associated with a bunch of other congenital abnormalities, especially renal agenesis and a lot of other abnormalities of the uterus, which we didn't have. So it could be either or. It could be just that there were so many surgeries and maybe it caused an adhesion and the ovaries kind of got stuck in that process. And the
Then
fact,
you're thinking these are like peritoneal inclusion cysts around each of these ovaries? Well, I can't hear you. Tarun, are you still there?
Sorry, his microphone just shut off.
Okay.
Hold on 1 second, he's coming.
Okay.
so I think there's some technical issues. So what I was saying is that the fact that there are like cystic areas around these ovaries, it's also possible that there are adhesions and there are some inclusion cysts. So that's our working diagnosis right now.
Cool. One other thing that I just thought about is that some people who have cervical cancer and need radiation, they'll actually do a transposition of the ovaries into the upper abdomen to remove them out of the radiation field and preserve fertility. So
Right.
not in this case, but just another thing to think about if you see ovaries that are in the abdomen, like not in the
Yes.
pelvis. So,
Yeah, this is a very young patient.
yeah, cool. Okay.
This is a really interesting case. Patient with history of diffuse liver disease and then got screening MR. And this is what we see. So this is our T2 pre-arterial in 5 minutes. And we gave this lesion, well, what would you give this lesion?
Can I see diffusion?
Yes.
I mean, base.
It's mildly arterial hyperenhancing, definitely washing out, and looks like it has a capsule. So I think I would give it a 5. Lyrad's 5.
I mean, on some images, it almost has rim APHE, so I don't know. I just want to see the DWI. I may have gone with an M. I want to see, like,
this was an outside MR and there's no diffusion, which is crazy.
oh, it's not helpful.
But
Can you
we
scroll
do
through
have a
arterial phase
subsequent,
up and down?
we do have a subsequent diffusion that we did. So here it is on a later MR, but this is after local regional therapy. So it's a little altered.
That's not helpful.
Yeah, sorry.
Can I see
So
the
there-
arterial phase up and down?
Yes.
The
Yeah,
original?
let me give you the original pre-treatment arterial is this one right there. And then the here's a 5 minute. What do you think,
And can you scroll
Victoria?
further down and I just
I
want to see how
would've-
good the arterial phase is. Because it
I
seems
mean-
kind of late.
But we're supposed to
Yeah,
get
but
late
I
arterial.
mean,
That's not.
yeah.
But I mean,
That's-
even later, because
I
like
don't-
the portal vein has a lot of flow in it.
I think that this is a good example of, like, if you're not sure, like rim versus non-rim, like, I think I would have had to have gone with rim here because, like,
Sorry, let me
Most-
just
and-
introduce
and-
to the group. So Victoria Chernyak, who's talking. We have a lot of trainees on this conference right now
Hi, guys.
from Mayo. Victoria, she chairs the LIRAD steering committee. So we have the queen of
Great.
LIRADs on board. So teach us about.
No, but so, I mean, Aarti makes a good point that we are like right at the end of the later arterial phase. It's possible that like this particular lesion began to wash out, and what we're seeing is that the center is beginning to wash out. And if we acquired just like maybe 5 seconds earlier, it wouldn't look like this. But with the images that we have here, everywhere you scroll, the enhancement is primarily in the periphery, and the center remains centrally hyper-enhancing. So this is a great example of like, what do? You go with rim or non-rim, and the rule is if you're not sure, like if there's any doubt, you have to go with rim. So in this case, I would have begrudgingly, like without, I would begrudgingly say, okay, I have to give it an M, because based on what you're showing me, this arterial phase, I would have to stick with rim arterial phase hyperenhancement and make it an M. But I agree with Aarti that there's a good chance it's going to be an HTC. But strictly speaking, that has to be an M.
And you're right, Victoria. Patient went
What
for a
it came out as.
transplant, and it was a biphenotypic. There was a combined hepatical like a biphenotypic hepatical cholangio and a pure cholangio next to each other.
That's a great case. What a great case.
So it was
Not for
a
the patient,
4
but-
centimeter. So it was. So these were actually 2 lesions. It's almost like a collision tumor. So we reviewed it on the
So, like,
explant,
yeah.
and
But
they're
see,
like,
this is
"Oh,
like
is
a
it 2
good
or 1?"
example.
And it looks like 1, right? I mean, by imaging. And
Right.
so this is for the trainees. This is typically we don't do transplant for biphenotypic. So biphenotypic means it has components of HCC and cholangio. So if we know that, patients are no longer candidates for transplant. So this is important to know, and they're typically classified as LRM. But in the literature, biphenotypic subtypes are misclassified as LR5 in 1/3 to 1/2 of the cases. And this
Well-
was, go ahead.
Right. Well,
Nelly-
so
Oh,
so there are 2 things here, right? So there are some like combined tumors that actually meet criteria for LR5. So they're not miscategorized. They actually just meet criteria.
Yes.
And those tend to behave biologically as conventional HCCs. There are few papers that show that the prognosis-wise, those combined tumors behave more like conventional HCCs, so maybe that's not such a good idea. This tumor, this particular case, if you apply LIRADs appropriately, this should be categorized as M. So this, right? Like, I didn't know what it was going to be. I told you I would have gone with an M. But it makes sense, right? That's why it was washing out. That's why it had a capsule, because it did have the hepatocellular component. But this is, again, like highlights the importance of this rule where if you're not sure between M and a 5, you go with M, because for these cases, because there are this tricky case, tricky tumors which can mimic HCC. And this is a great example where, patient received transplant when, theoretically they shouldn't have.
this is
Love
amazing, Victoria, because I guess I wouldn't have called rim here, but you're saying because the rim is more enhancing than the central part, that's why you're calling it rim.
Right. It doesn't have to be rimism like an actual. Sometimes we see rim arterial phase enhancement as true rim, right? And then it's easy. But definition is enhancement in arterial phase, which is more pronounced in periphery than in the center, which is, if you look at it, and that's why I asked Nelly, just scroll up and down and see what it looks like. And as she was scrolling, and sometimes you can get like one slice that kind of sort of looks like it, but as you go up and down, you see that no, this is just like you caught one area. But as you scroll up and down here, notice that everywhere you look, the enhancement, most of enhancement is in periphery. And however she scrolls up and down, the periphery invariably enhances more than the center.
Mm. And Nelly, can you
So
show the
with this-
delay? I just want to see like
And
the
so,
washout
but-
part.
and-
Okay.
Right, and then remember, for LRM features, any one of the LRM features is enough to go, you know, that this is LRM. So it doesn't matter what else is there. It doesn't matter if there's fat and mass. It doesn't matter if there's, like, nothing else matters. Once you have any one of the LRM features present, you go with LRM. And again, let's say if Nelly said this came out to be HCC, categorizing HCC, like having LRM that on path came back as HCC is not an error, but this way is an error. Does that make sense?
Yeah.
So does that
Another
make sense what I'm
question.
saying?
Nelly, in your path report, it said there was a diaphragmatic mass and also a falciform mass. Like
Mhm.
in retrospect, could you see any of that or no? That was
So
like
the
probably
pa-
developed later.
So the patient had I think it was Y90, local regional therapy. And then this was the pre-operative, or oh, sorry, that's a post-explant. Let me find it. And oh yeah, so here's the post right there, and you can see the bulging here. And it was extensive disease involving the falciform ligament, and it was like really close to the pericardium. So that's why we reviewed it. So you can see stranding here, but I don't see a tumor extending into it. And I think this was a surprise.
Interesting.
What a cool
Okay.
case. Thanks for showing it, Nelly.
Thanks for the education.
Yeah, thank you. I'm going to stop this for a second. Okay, so this person has abdominal pain. I'm looking for input. Oh, let me take off the. So I'll just point out a couple of things. There's an obvious thing. There's a fluid collection in the abdominal wall here in the right lower quadrant, with a lot of interesting nodularity of the overlying subcutaneous fat. And then a few additional findings in the pelvis. They have chronic renal disease, really atrophic native kidneys. They have one failed left lower quadrant renal transplant. They have an additional right lower quadrant renal transplant. Anything else?
There's a lot of soft tissue in the right lower quadrant, right there.
This stuff?
Yeah.
Yeah, what is that?
I wanted to say pancreas, but it'd be weird. Like
Yes.
it looks like a pancreas, like a
Yeah. So
pancreatic
why is there a
transplant.
pancreas in the right lower quadrant?
Pancreatic transplant, no?
Yeah, exactly. So this is a pancreas transplant. Very nicely seen on the coronal here. So what else? So can you tie it all together? So basically, if you saw this nodularity in the peritoneum, the omentum, and
I think
retroperitoneum,
pancreatitis, but
exactly.
I
Right?
mean
You would think about-
pancreatitis involving the soft tissues, that'd be so weird.
So anyway, this is fat necrosis and saponification from pancreatitis. And this is a pancreas transplant that was done a very long time ago, and it was connected to the bladder. And you can see that there's, irregularity of the bladder and the fluid and blah, 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 right? So anyway, basically they drained this collection. We tested it for amylase and lipase, so it was very elevated. They then did let me bring up this. They then did a CT cystogram. And so now the fluid collection has been drained. There's a drain there. There's a CT cystogram. There's contrast in the bladder, and it has fistulized into the abdominal wall. So you can see the connection both with the pancreas and then also into the abdominal wall and into this collection. So early on in pancreas transplants, they actually connected it to the bladder. They did this because they were not very, they tried to connect it to so for the exocrine pancreatic juices, they want to connect it to, take a piece of the duodenum and connect it to small bowel so that you can get your exocrine juices. But early on, actually, it wasn't very successful, and they got a lot of fistulae with the skin. So they started connecting it to the bladder, and that worked for a while, but it would cause alkaline cystitis. And then in this case, for example, all these pancreatic juices eventually eroded the bladder wall and caused this fistula that led to this like abdominal wall, basically pancreatic collection and fat necrosis. And I'll just show you. Try to bring in the pancreas transplant anatomy here. Sorry. Okay, doesn't seem to be working. Let me just move this over here. Okay, can you guys see this? Are you still there? Okay. Okay. So basically, this is an example of a pancreas that the duodenal loop was connected to the bladder. This was done like 25, 30 years ago. Now they have much better immunosuppression and better surgical techniques. So they're able to connect that duodenum to the small intestine so that all of the pancreatic juices can be drained here and actually help with digestion of the food rather than causing alkaline cystitis. And then just as a review, pancreas transplants are mainly done for people who have brittle diabetes and are already getting a renal transplant, and you want the insulin to be going to the bloodstream. So they make this Y graft with the SMA and the splenic artery that will connect to your common iliac artery. And then they'll also connect the SMV and splenic vein, portal vein, into the common iliac vein. I guess, any comments, questions?
Keter said, what a great case.
Oh, cool. So yeah, this was basically a pancreas transplant connected to the bladder, eventually caused a bladder cutaneous fistula abdominal wall collection. One of the teaching points is if you ever see nodularity like this in your omentum, in your retroperitoneum, and now even in your subcutaneous tissues, think about saponification and fat necrosis from pancreatitis.
I read CTCs, and this is a great example of a finding on CTC that I don't commonly see. So this is here, there's a lesion here, and just a really great example of apple-core lesion in the sigmoid, kind of distal descending sigmoid junction. I wanted to show this because most of the CTC I read are negative. And so this is a great example of a positive CTC, which turned out to be sigmoid cancer right there.
Cool. Do you, he didn't have any bleeding?
I think the patient was symptomatic and then got this. This was an old study. I was reading a follow-up study. And yeah.
Cool. Okay, I'm going to share another one. want your input. This is a patient who has HIV and has rectal pain. Any thoughts?
So there's rectal wall thickening, and I think AIDS patients get solitary rectal ulcer syndrome.
Good thought. So severe wall thickening, hyperenhancement, a lot of fat stranding, engorgement of the vascular vessels going all the way down. And then there's also some lymph nodes. So I was reading this and I was like, okay, this is severe proctitis. This could be due to any number of infections, including crypto or HSV, lots of different things. And then we looked into the chart and we found out that this was an HIV positive patient who recently is a male patient who recently had a sexual encounter with another male, and that other person tested positive for monkeypox. And they swabbed the rectum here and it tested positive for both HSV and monkeypox. So this is my first personal case of monkeypox infection. So I thought it was interesting.
Oh my goodness. How do you treat, how is that treated?
So there's a few different things. Hold on, let me just pull up. I have some information about it. But so monkeypox is related to smallpox. It's been around for a very long time. People who are immune to smallpox have some immunity to monkeypox. So there are some like high-risk patients that are actually getting vaccinated against monkeypox with the smallpox vaccine. It is actually often, it basically creates pustules and rashes on the skin, especially involving the genitalia. And it's so a lot of it affects immunocompromised patients more, and it's being diagnosed more in patients like men who have sex with men. And let me see, what did I read? Oh, people who are immunocompromised can develop pneumonia and encephalitis. So our neuro colleagues might be diagnosing this. But I think there is a possibility we're going to be seeing more kind of severe proctitis like this due to monkeypox. And it's treated with, there's like an experimental antiviral that they're treating it with if you have severe disease. And it's called tecovirimat, which is an antiviral agent against smallpox. Its supply is limited, and so they're only using it to treat people who have severe monkeypox infection.
Wow.
Wow.
Yeah. And so, yeah, I put it in my report. I said, like, this is compatible with the swab positive monkeypox infection. And then these lymph nodes may also be involved with monkeypox. So. Okay, Nelly, you're up.
Okay, patient with pelvic pain. Yeah, just
Wait, is that another mushroom cap?
okay, where?
On the like rectosigmoid junction there? And they're, wait, hold on.
Whoa, sorry. Is that not, what were you referring to?
That thing there, but wait, is this a male or female? Scroll
It's a
through.
woman.
Okay.
Hysterectomy.
And I see like,
There's
all right.
vaginal canal.
Okay. And then scroll through the rectosigmoid. I thought I saw like a mushroom cap right there.
Yeah, good. What else?
And like deep infiltrating endometriosis next to it as well.
Next to where? So here's the, good. So there is this, right? The mushroom cap. It's a beautiful example of a mushroom cap from deep infiltrating endometriosis. And then on MR, there's another area of deep infiltrative DIE right here. That's a little bit lower right there.
2 mushroom caps.
2 mushroom caps.
A mini one. A
And to
little
top
baby
it
one.
off, this is the surgical specimen
Oh my gosh, that's so
of the
pretty.
larger one.
So, Nelly, you've talked about how we have to describe like the extent of wall disease and
Mhm.
depth and stuff. So it sounds
Mhm.
like in this case, did they end up doing just like an anterior rectal resection, or did they remove the whole thing? Like, what did they do?
They removed the segment entirely. So the colorectal surgery got involved. We meet with our gynecologist for endometriosis boards. So when there is rectal involvement, we say what circumference is involved. So in this case, it's, see, this is annular or semi-annular, it's by semi-annular. And then we describe the depth of invasion. If it's superficial, it's the outer serosa, they just scoop it out. If it's deep invasion, then they do a resection, like a segmental resection, and colorectal surgery gets involved. So circumference and depth of invasion.
Okay. Yeah. So this one was too deep.
Mhm.
Yeah.
And there's 2 sites, which was important to know in advance, so that they get both, and was confirmed surgically.
Yeah. It looked almost like it was like tethered to the vaginal apex, but they didn't have to do anything over there.
I didn't appreciate the tethering to the vaginal apex. Here's the vaginal apex.
Like, or even like a small bowel loop, like right there. Those things aren't all tethered together. Like right there.
Here, yeah.
Yeah.
I think the small bowel is fine. And that's the one area that we're still kind of calibrating. The rectum, we do really well, but the small bowel, we're still figuring out. For me, if there's distortion, then that has a high PPV, high yield. So I called a case, and maybe I'll find it, where there was DIE and the small bowel was right next to it. And so I called small bowel DIE, and surgically there was small bowel is fine. So it was just right next to it without being involved. And in retrospect, there was no distortion or anything like that.
And Nelly, when do you give vaginal gel?
We do it for these endometriosis cases. And
We also
do
just
it during
developed
the picograms.
We also just developed an endometriosis protocol where we give vaginal gel. Okay, this is my next case. So there's already some findings here. Any thoughts?
There's venous thrombosis.
Mm-hmm.
And there was PE.
There were
Yes.
nodules in the lung.
Uh-huh. So I'll show you the chest CT as well. This is where the venous thrombosis kind of stopped. And then this was the chest CT. So pretty extensive PEs bilaterally. And some peripheral little pulmonary infarcts. And then back to our abdominal exam. The IVC looked pretty good. We did a venogram, a CT venogram. So for the trainees, this will be around 110 seconds to 2 minutes. And so we can get nice opacification of the IVC and the iliac veins without mixing. And we're seeing this thrombus go all the way up here. So anyone want to give me the diagnosis? And the DVT went all the way down the leg. So we actually did a veno runoff and it went all the way down here. So you can actually get a really nice venogram of the leg. Somebody's writing into the chat. Yeah, Maria got it. So it's May Thurner syndrome. So this is more common in younger females. And it's basically, if we get back to our important area, it's basically compression of the left iliac vein from the right iliac artery. And they measured it here as 3 millimeters compared to 9 millimeters here. So our vascular surgeons went in, they did a thrombectomy, they did fluoroscopy, and they also did intravascular ultrasound where they saw that there was actual compression here. So then they felt confident that it was actually May Thurner's, and they placed a stent, a long stent from the IVC into the iliac vein, and did a complete thrombectomy. So anyway, nice case of May Thurner's.
This is a patient pre-renal transplant evaluation and got a non-contrast CT to look for vasculature. So adult polycystic kidney disease. Having gone through that phase where we had contrast shortage, I didn't used to really like reading CT non-con, and then I come to realize that you can still see a lot with
Appendiceal and
non-con CT.
mucocele.
Yes, yeah. So it was incidental finding. I think you can see it better on the coronal, but there's this large dilated appendix that goes to the cecum. There's calcifications, which we can see with adeno or mucin, anything that secretes mucin. And this was incidental mucocele. And they do an appendectomy because they can harbor adeno-CA.
Very cool. I always feel a little uncomfortable with these non-cons with polycystic kidney disease and all these lesions. I don't know what, shouldn't we be evaluating them more? But yeah. Okay, I don't have any others. Nelly, do you have any more?
That's it for me.
Okay, great cases. Anyone else? Gitanjali, nice to see you again. Nice to have all the Mayo Fellows.
And faculty.
And faculty.
We have Al Silva and then Maria Zulfikar, who just joined us from Melancrot.
Cool.
Welcome, everybody.
Okay, we'll bring your cases next week. We'll see you then. Bye.
Bye, everyone.
Okay, bye, guys.